Hi, welcome to our Prescribing and Surgery series. This is our 8th session, which will be on general surgery, colorectal, and urology. And my name's Dr. Aisha Musa. I'm one of the co-leads for the Prescribing and Surgery series. So just a disclaimer, the series has been created by junior doctors who have a passion for teaching. It's entirely on a voluntary basis, and the lecture slides and teaching contents are accurate to the best of our knowledge, and neither us nor the Mind the Bleep take responsibility for any unintentional inaccuracies. And our session next week by Dr. Jemmett will be on TNO, ENT, and pediatrics. So straight on to the first case. A 54-year-old man presents to the surgical emergency assessment unit with severe left iliac fossa pain, bloody diarrhea, and a fever. He has a past medical history of asthma, for which he takes salbutamol 4 milligrams TDS, and he has no known drug allergies. A CT scan is conducted, which shows acute diverticulitis with generalized purulent peritonitis. The general surgical consultant asks you to commence him on antibiotics whilst he awaits his surgical procedure. So the first question is, which antibiotic will you prescribe for his acute diverticulitis? And I'll just release the pool. So far, most people are going for option A, which is Colorectal 1.2 grams IV TDS, with some going for options D, doxycycline and metronidazole, and options E, levofloxacin. Okay, any more responses? Okay, so far, most people going for A, followed by E, and then D. Okay, so the correct answer is A. So the correct answer is A because he has complicated diverticulitis with generalized purulent peritonitis, and he's not allergic to penicillin. The reason why it's not B is because fidaxomicin, 200 milligrams per oral BD second line vancomycin is ineffective in patients with C. difficile infection. The reason why it's not option C is because option C is used in non bolus impetigo in patients who are not systemically unwell or at a high risk of complications. The reason why it's not D is because doxycycline and metronidazole is used to treat human and animal bites in patients who are pen allergic. And the reason why it's not E is because this is an alternative choice for human acquired pneumonia, but this is only in if specialist, if kind of approved through specialist advice. So this is just to show you to the left, the BNF guidelines, which says in patients with suspected or confirmed complicated acute diverticulitis, first line IV, you start them on comoxiclav. And to the right, just showing you my local guidelines, which say the same thing. Okay, any questions for this case? Okay. Alternatively, you could give ceftriaxone with metronidazole or amoxicillin with gentamicin and metronidazole, but neither of those were kind of listed in the multiple choice. Okay, let's move on to the second case then. So case 2, a 35-year-old female presents to her GP with constipation and pruritus. She denies rectal bleeding. PR exam shows external hemorrhoids that's not thrombosed. She's got past medical history of hypertension, for which she takes Ramipril 2.5 milligrams once daily. She has no known drug allergies. She's given antiseptic cream to aid with the itching and painkillers. and you've been asked to prescribe laxatives for her constipation. So which laxatives will you prescribe for her constipation? Just release the second poll. Someone said the slides are moving forward. Okay, let me just go backwards and then forwards. And it should say case 2. Okay, so far, 40% of people going for option A, lactulose, 40% going for option B, macrogol, and 20% going for senna. Okay, any responses? Okay, fine. So the answer is actually E, which is esophageal husk. The reason why is that in the BNF it says that in patients with hemorrhoids, if constipation is reported, it should be treated using a bulk forming laxative. So options A and B are osmotic laxatives, option C is a stimulant laxative, and option D is a stool softener as well as a stimulant laxative. And this is showing you at the top, that's taken from the BNF, which says if constipation is reported, it should be treated using bulk forming laxative in patients that have hemorrhoids. And just showing you the 2 most common examples of bulk forming laxatives, which is fibrogel, also known as esophageal husk, and methyl cellulose. Okay. Any questions for this case? Okay, I'll move on to the next case. Someone said they can't see the questions. I've just released the questions into the into the chat via the poll. Okay, so moving on to case 3. Let me know if you can see the questions for case 3. So case 3, a 42-year-old male presents to A&E with a fever, dysuria, and straining when urinating. He has no past medical histories. He's not currently on any medications, has no known drug allergies. The PR exam shows tender and boggy prostate. The blood and urine cultures have been taken. Painkillers have been prescribed. And he's been referred to the urology team. The urology team have asked you to prescribe him antibiotics for his prostatitis. So the question is, which antibiotic will you prescribe for his prostatitis? And I'm just going to release the poll for question 3 into the chat. So 80% of people are going for C, ciprofloxacin 500 milligrams BD, 83% now, with 16% going for nitrofurantoin 100 milligrams modified release BD. Okay, any other responses? Okay, so currently C is the most popular option, followed by A, levofloxacin, and then E, nitrofurantoin. Okay, So the correct answer is C, ciprofloxacin 500 milligrams per oral BD. I'll go through why it's not the other options. So it's not A or B because so levofloxacin 500 milligrams OD as well as cotrimoxazole 960 milligrams BD are both second-line alternatives for prostatitis, and they are only initiated on specialist advice. It's not D because flucloxacillin 1 gram QDS is used for cellulitis, and it's not E because nitrofurantoin is used for UTI and it does not help in prostatitis. So this is just showing you that oral first line for acute prostatitis is either ciprofloxacin or ofloxacin. And to the right, just showing you my local guidelines, which show 500 milligrams per oral BD of ciprofloxacin for acute prostatitis. Any questions for this scenario? Okay, can move on to the next case. So case 4, a 28-year-old female presents to A&E with dysuria, polyuria, urgency and foul-smelling urine. She's not pregnant. Her symptoms have not improved over the past 48 hours. In terms of her past medical history, she takes fibromyalgia, for which she takes citalopram 10 milligrams OD. She has no known drug allergies. You've taken some bloods from her, and her EGFR is 92. You have been asked to start her on antibiotics for her UTI. So the question is, which antibiotic will you prescribe for her UTI? Just release the poll into the chat. So we've got 5 responses so far, with 100% of people going for B, nitrofurantoin, 50 milligrams QDS. Okay, any more responses? Okay, so 75% of people going for B, nitrofurantoin, 50 milligrams QDS, with 25% going for A, phosphomycin 3 grams as a single dose. So the correct answer is B, nitrofurantoin, 50 milligrams QDS, but I can talk through why it's not the other options. So options A, C, and D are all second line for UTI in non-pregnant women. And this is used if there's no improvement after at least 48 hours, or the first line is not suitable. Option B is correct because this is the first line treatment for UTI. It is not E because acyclovir 800 milligrams 5 times a day is used for chickenpox. So this is just showing you in non-pregnant women, first line, you would prescribe nitrofurantoin or trimethoprim. And we tend to use nitrofurantoin over trimethoprim. We only tend to use trimethoprim if there's low risk of resistance. And her EGFR was above 45, so we're okay to use the nitrofurantoin. Any questions for this case? Okay, let's move on to the next case. So case 5, a 60-year-old male presents to A&E with foul-smelling urine, dysuria, fever, urgency and frequency of urine. Urine culture has been taken. In terms of his past medical history, he's got right knee osteoarthritis. He doesn't currently take any medications, and he has no known drug allergies. It's noted that his EGFR is 35. You have been asked to commence him on antibiotics for his UTI. And so the question is, which antibiotic will you prescribe for his UTI? Just release the poll into the chat. So far, 100% of people going for B, trimethoprim BD, 200 milligrams. Any more responses? Okay, so far, everyone's gone for B, trimethoprim 200 milligrams BD, which is the correct answer. So the reason why it's not A is because phenoxyethyl penicillin 500 milligrams QDS is used for acute sore throat. The reason why it's not C is because amoxicillin 500 milligrams TDS, it can be used in UTI, but it tends to be used in catheter-associated UTI at first line if culture sensitive, or second line in non-pregnant women or pregnant women. This is again only if it's culture sensitive. The reason why it's not D is because amoxicillin, clindamycin, omeprazole, it's triple therapy used for H. pylori. And the reason why it's not E is because ofloxacin 200 milligrams BD is used for epididymitis. And this is just showing you that it's trimethoprim, 200 milligrams BD per oral, because his EGFR is more than 30, but it's less than 45, so we can't use nitrofurantoin. I hope that makes sense. Sorry, any questions for that case? Yes, the recording will be made available after the session, along with the slides. Okay. So moving on to our sixth case, a 30-year-old pregnant woman presents to A&E with a fever, left loin pain, and nausea and vomiting. On examination of her abdomen, she's got left costovertebral angle tenderness. In terms of her past medical history, she's got eczema. She doesn't take any medications for it, and she's not on any other medications. And she has no known drug allergies. So urine culture has been collected, and she's been referred to the urology team, who have asked you to prescribe antibiotics for her pyelonephritis and to order a renal ultrasound scan. So the question for this case is, which antibiotic will you prescribe for her pyelonephritis? And I'll just release the questions into chat. So far, 60% of people going for D, cephalexin, 20% going for E, ceftriaxone, and 14% going for C, flucloxacillin. Okay, any more responses? Okay, so equal amount of people going for D and E, with 11% of people going for C. Okay, so the correct answer is D, cephalexin, 500 milligrams, 2 to 3 times a day per oral. And I'll just go through why it's not the other options. So clotrimazole cream is used for vaginal candidiasis in pregnant women. Metronidazole 400 milligrams BD per oral is used for bacterial vaginosis. Flucloxacillin 500 milligrams QDS is the dose we would use for patients that present with mastititis. And it's not E because ceftriaxone 2 grams IV BD is what we would use for meningitis. So just to show you the guidelines. So to the left, we've got the guidelines, BNF guidelines for pregnant women with pyelonephritis. And as you can see, oral first line is ceftriaxone. To the right, we've got guidelines for non-pregnant women and men. And in that case, we can use cephalexin or ciprofloxacin. We could also use comoxiclav or trimethoprim as well as oral first lines if sensitivities are known. I hope that makes sense. Any questions for this scenario? Okay, so then we can move on to the next case, which I think's our last case for today. So a 50-year-old man presents to A&E with right loin to groin pain, which is severe and associated with nausea and vomiting. So in terms of his past medical history, he's got epilepsy for which he takes carbamazepine 200 milligrams BD per oral, and he's got no known drug allergies. So his non-contrast CT KUV shows a distal ureteric stone, which is 7 millimeters in diameter. He's seen by urology and scheduled for shockwave lithotripsy, and the urology registrar asked me to prescribe adjunctive medical therapy. So the question is, which adjunctive medical therapy will you prescribe for his distal ureteric stone? I'm just going to release the question to the floor. Someone asked, pyelonephritis can prescribe orals? Yes, you can. You can prescribe orals as first line. You can also prescribe IV as first line if they're severely unwell or unable to take oral treatment. So just in terms of the responses for question 7, so 42% of people saying tamsulosin, with 28% of people saying vancomycin, and 28% of people saying watchful waiting. Any more responses? Okay. Okay, so 44% of people going for C tamsulosin, 32% going for watchful waiting, and 22% going for vancomycin. So the correct answer is C, tamsulosin, 400 micrograms OD per oral. So the reason why it's not A is because we tend to do watchful waiting for asymptomatic renal stones, or stones if they're less than 5 millimeters in diameter, and his stone was 7 millimeters in diameter, and he's symptomatic. The reason why it's not B is because hyacinth butyl bromide is used for symptomatic relief in GI or GU disorders caused by smooth muscle spasm. And in the BNF, they mentioned not to offer antispasmodics to patients with suspected colic. So C is the correct answer. The reason why it's not D is because chloramphenicol is used for conjunctivitis, and the reason why it's not vancomycin 125 milligrams QDS is because it's used for C. difficile infection. So this is just from the BNF showing you that alpha adrenoreceptor blockers can be considered as an adjunctive therapy for patients having shockwave lithotripsy for ureteric stones less than 10 millimeters. And he's undergoing shockwave lithotripsy for a distal ureteric stone that is 7 millimeters in diameter. I hope that makes sense. Any questions for this scenario? Okay. So these are the references for today's that I used for today's session, and this is a feedback form that I'll just release into the chat. So the feedback form is very helpful for us because it helps us know what we've done well, how we could improve. I know today's talk was a bit shorter than previous talks, but we've got kind of more talks coming up in the future. And please do fill out the feedback form because it allows you to have a certificate for your attendance. And as I mentioned earlier, next week's session will be on trauma and orthopedics, pediatrics, and ENT by Dr. Jemmett. And this is our 8th session out of our 10-part series. So thank you very much for joining us today. I hope it was useful.